Okay, students, this is your instructor, Diane Pizzacreta, and we are now going to be moving on to Chapter 9, Schizophrenia. In the first segment, I'm going to be reviewing our learning objectives, as I always do, and then I'm going to go on and talk about the symptoms of schizophrenia. Slide 2. So what are the learning objectives? What are the things that you need to master by the end of the chapter? First, you need to be able to describe the clinical symptoms of schizophrenia, and that is going to include the positive, negative, and disorganized symptoms. You need to be able to differentiate the genetic factors, both behavioral and molecular, in the etiology of schizophrenia. And I'm going to point out here that we're going to spend quite a bit of time talking about the etiology of schizophrenia. You need to be able to discuss how the brain has been implicated in schizophrenia. Be able to describe the role of stress and other psychosocial factors. And finally, we're going to spend some time discussing medication and other psychological treatments. So you need to be able to distinguish the medication treatments and the psychological treatments for schizophrenia. Slide 3. So what is schizophrenia? Schizophrenia is defined as major disturbances in thought, emotions, and behavior. Schizophrenia really impacts every function of a person, the ways they think, the ways they feel, and the ways that they behave. If we look at schizophrenia as a root word, it means broken personality, but don't be confused or get confused between schizophrenia and personality disorders. Schizophrenia is different. When we're talking about these major disturbances in thought, emotion, and behavior, what I'm talking about here is primarily disordered thinking, that the individual is not logical, their ideas are not related, and they have faulty perception and attention. Emotional disturbances are really referring to a lack of emotional expressiveness. They have an inappropriate emotion, they express inappropriate emotions in certain situations, or they have absolutely flat emotion, no emotion whatsoever. And then there are disturbances in behavior, disheveled appearance, agitated behavior, and we're going to talk about all these things in detail. One of the things we know about schizophrenia is that it can disrupt interpersonal relationships. It diminishes capacity to work or to live independently. And individuals who suffer from schizophrenia are at a significantly increased rates of suicide and death. Individuals who suffer with schizophrenia are about 12 times more likely to commit suicide than the general population. Slide 4. The lifetime prevalence of schizophrenia is about 1%. And I want to point out here that when I say 1%, I'm really talking about globally. In nearly any country that has looked at this, we see about a 1% rate of schizophrenia, just less than 1% rate of schizophrenia. This leads us to believe that this is probably primarily physiologial or genetic, but we're going to talk about that in more detail a little bit later on in the lecture. We do know that it affects or impacts men slightly more often than women. The onset is typically in late adolescence or early adulthood, and men do have a tendency to be diagnosed at slightly earlier ages than women do. We do know that it's diagnosed more frequently in African Americans. However, this may reflect a diagnostic bias. So it may be that what we're seeing is a bias in the counselor or the psychologist or the psychiatrist, rather than reflecting a true difference in the population. One of the things about schizophrenia is really it is a lifelong disorder where the individual is going to have acute episodes with less severe episodes between. Slide 5. Alright, so what are some of the DSM criteria for schizophrenia? What we're looking for is 2 or more of the following symptoms for at least 1 month. And one of the symptoms has to be 1, 2, or 3. So what we're looking for is at least, for at least a month, this person has experienced delusions, hallucinations, and disorganized speech. Other symptoms can include disorganized behavior, catatonic behavior, and other negative symptoms, such as diminished motivation or emotional expression. We're also looking for difficulty in functioning in work areas, relationships, and self-care, that this has declined since the onset of the symptoms. Slide 6. There are really three broad domains, or three major clusters of symptoms: positive, negative, and disorganized. When we're talking about positive symptoms, I'm really talking about things like delusions and hallucinations. Those are sort of the hallmark symptoms of schizophrenia. Some of the negative symptoms include things like blunted affect, asociability, alogia. Essentially, the person lacks emotion. They stare off into space. We'll talk about these in more detail. And some of the disorganized symptoms include disorganized behavior, disorganized speech, that there's no logical connection to what the person is saying or doing. So slide 7. So when we're looking at positive symptoms, primarily what comes up are delusions. Delusions are firmly held beliefs that are contrary to reality. The individual is very resistant to disconfirming evidence. Even when several people or the evidence itself is present, they still hold on to these delusional beliefs because they feel or seem so real to them. Different types of delusions include persecutory delusions, things like the CIA is watching me, it's listening to me, the government is listening to me, people are after me. About 65% of schizophrenics do experience persecutory delusions. Things like thought insertion. The government is putting thoughts in my head. Thought broadcasting. Other people can hear what I'm thinking. Outside control, that some outside force is controlling or creating the behaviors or emotions that this person is exhibiting. Grandiose delusions, an exaggerated sense of power, an exaggerated sense of identity. Ideas of reference, pulling in these sort of unimportant events within the delusions and reading significance in them, seeing trivial events as being very significant or very meaningful when they're not. Hallucinations are sensory experiences in the absence of sensory stimulation. So in other words, you're seeing things that are not there, or you're hearing things that are not there. And primarily when we talk about hallucinations, they are either visual or they're auditory. About 74% of schizophrenics have some sort of auditory hallucination. Primarily, they're hearing voices. We're not sure why schizophrenics seem to have an increased level of auditory hallucinations. There's several theories. The research seems to indicate that what is happening is a misattribution. They're hearing their own voice inside their head, and we've all done this, where we're thinking about things and there's a sort of a running voice inside our head, and we recognize it as our own. But the belief is that schizophrenics don't recognize that voice as their own. They believe it's another person's voice. Several neuroimaging studies suggest that there's overactivity in both the Broca area. In Broca's area, it's in the frontal lobe that produces speech, and also in Wernicke's area, which is in the temporal lobes. And remember, that's on the side of your head, and that does speech comprehension, auditory comprehension. And so these increased levels of activity in Broca's area and also in Wernicke's area seems to happen while the individual's having hallucinations. When hallucinations happen, it is not completely uncommon for other psychological disorders to be diagnosed, particularly bipolar. It's not uncommon, and this is a reliability problem and a diagnosis problem that psychologists and psychiatrists are struggling with. The ability to be able to tease apart when a person is bipolar and when they are schizophrenic. Slide 8. So what are negative symptoms? Negative symptoms really tend to continue once that person gets past the acute phase. Things like avolition, which is really a lack of motivation, sort of a lack of interest and apathy towards things. Asociality, an inability to form close personal relationships, a disinterest in other people. Anhedonia, an inability to experience pleasure. When we experience pleasure, it's usually consummatory pleasure. So in other words, a pleasure that you're experiencing in the moment, or an anticipatory pleasure that you're expecting something exciting to happen. We see that a lot in little children when they're counting the days off to Christmas. They have a lot of anticipatory pleasure, the excitement that it's coming. These sorts of pleasure, someone who is struggling with schizophrenia doesn't experience. They have a blunted affect. They exhibit very little or no emotion in their face or in their voice. The outward expression of emotion is really subdued or blunted. But there's a lot of research that shows people with schizophrenia, even though they're less facially expressive, they're still having emotions on the inside. They're still fully feeling those emotions, even though they're not expressing those emotions. Alogia, reduction in speech. They become silent or they talk very little. These negative symptoms can be grouped into two domains. Experience domain, which is connected to motivation, emotional experience, sociality, and then the expression domain, which is the outward expression of emotion and vocalization. Slide 9. Disorganized symptoms primarily focus in on disorganized speech, which is also known as formal thought disorder, that the person seems simply incoherent. They have no ability to organize their ideas. They engage in a lot of loose associations and become derailed. They ramble on. They're unfocused. They have difficulty sticking to any particular topic. Disorganized symptoms can also include disorganized behaviors, odd behaviors, peculiar behaviors. It's not unusual for people that are schizophrenic to engage in bouts of agitated behavior. They gesture wildly. They pace. They engage in unusual dress, silliness. For example, wearing several heavy coats in hot weather in the middle of the summer. Slide 10. Movement symptoms also include things like catatonia, which really refers to motor abnormalities, repetitive, complex gestures, usually with the fingers or the hands, excitable, wild, flailing limbs, arms sort of flailing about, or it can mean catatonic immobility, that they maintain an unusual posture for a long period of time. They stand on one leg. I remember when I went to the University of Cincinnati, there was a homeless man who was obviously schizophrenic. He would stand in front of a tree and hold it up for hours on end. He's engaging in what's called catatonic immobility. We might also see waxy flexibility, that limbs can be manipulated and posed by the other person, that the person can move their arm into a certain position and leave it there, and it will hang there. We do have a tendency to see less catatonic symptoms, probably due to the improvements in medication. But I also want to point out that there is some debate if catatonic schizophrenics or these catatonic symptoms should even be included with schizophrenia, that it may be actually a separate diagnosis. But for right now, for the purposes of this class and for the way the DSM is organized, we do still include catatonia and catatonic behaviors with schizophrenia. Slide 11. Other psychotic disorders. So as I mentioned before, according to the DSM, what we're really looking at is for at least 1 month the expression of certain symptoms of schizophrenia. And generally speaking, in individuals that have schizophrenia, it is a lifelong disorder with periods of acute symptoms that are followed by periods of less acute symptoms. There are a few forms of schizophrenia that are what we consider short-term, sort of a short-term schizophrenia. They include schizophreniform disorder and brief psychotic disorder. Schizophreniform disorder has the same symptoms as schizophrenia, but the duration is greater than 1 month but lasts less than 6 months. It includes hallucinations, delusions, and or disorganized speech. And then we also have brief psychotic disorder, where the symptom lasts from 1 day to 1 month. It's often triggered by some extreme environmental event, such as bereavement or grief. The symptoms must include either hallucinations, delusions, and or disorganized speech. Really, when we think about the big changes from the DSM-4 to DSM-5, there were very few changes in the criteria for schizophrenia. The biggest changes is that was the removal of the subtypes. And those subtypes were removed due to poor reliability. Clinicians were not doing a very good job of being able to apply those consistently. So those have been removed, and really the only two that are left are the two short-term, which is schizophreniform and brief psychotic disorder. Clinicians really consider schizophrenia now more of a spectrum disorder that goes from mild to severe, with these two disorders that are considered short-term. Now, there's also schizoaffective disorder, which has symptoms of both schizophrenia and either a depressive or manic episode. When we talk about schizoaffective disorder, what we're looking for really is symptoms of a major mood episode are present for a majority of the duration of the illness. So in other words, you've got a couple different things sort of going on here. Finally, other psychotic disorders include delusional disorder, where the person isn't experiencing any other symptom of schizophrenia other than delusions. And these delusions may be delusions of persecution, i.e. someone's out to get them, delusions of jealousy, delusions of being followed, erotomania. In other words, a famous person is in love with them, they become fixated or fascinated with a famous person, or even other somatic delusions. But all they are experiencing are the delusions, and there is no other symptom of schizophrenia.